Today we'll be discussing about atrophic rhinitis. What is atrophic rhinitis? As the name goes, atrophy in pathology means reduction in size or shrinkage of cells and tissues. It is a chronic nasal inflammation causing atrophy of the nasal mucosa and also of the turbinates of the nose. That is atrophic rhinitis. What are the causes of atrophic rhinitis? Atrophic rhinitis can be classified into a primary atrophic rhinitis and a secondary atrophic rhinitis. Primary atrophic rhinitis is atrophic rhinitis presents as the first or primary disease. The etiology or the causes for the primary atrophic rhinitis are it can be due to some infections, chronic infection of the nose. The most commonly implicated bacteria is Klebsiella ocina. There are other bacteria also like Coccobacillus, Pseudomonas aeruginosa, Proteus species, H. influenza. So many other bacteria are also implicated in causing atrophic rhinitis. But Klebsiella ocina is the most commonly implicated one because this bacteria colonizes the nasopharyngeal and oral cavity area. We also don't know whether this bacteria is causing the infection or if these bacteria are secondary invaders of these atrophied nasal mucosa. Other causes of primary atrophic rhinitis can be attributed to nutritional deficiencies. That is, deficiency of fat-soluble vitamins like vitamin A, D, iron deficiency, deficiency of protein malnutrition. All this can trigger the development of atrophic rhinitis. Another cause is there is a hereditary factor that affects the development of atrophic rhinitis. It is of polygenic inheritance. It can be autosomal dominant and autosomal recessive inheritance. Both types are studied in atrophic rhinitis. Also, atrophic rhinitis is seen in low socioeconomic class, that is people living in the low socioeconomic conditions because they are susceptible to having poor hygiene. Also, they neglect their health and they also can develop nutritional deficiencies which can in turn trigger the development of atrophic rhinitis. Another factor is autoimmunity. Certain recent studies show that autoimmunity against the nasal mucosa triggers atrophic rhinitis. Another factor is hormonal factors, especially atrophic rhinitis is seen in females after puberty. So there can be an estrogen progesterone imbalance that causes atrophy of the nasal mucosa. So to remember the primary atrophic rhinitis causes, you can remember the word inhale, INHALE. I is infection, N is nutritional deficiency, H is hereditary, A is autoimmunity, L is low socioeconomic status. E is endocrinological, that is hormonal or endocrinological. What are the secondary causes of atrophic rhinitis? Secondary causes can be secondary to some other primary disease, that is granulomatous disease like syphilis, leprosy, tuberculosis can cause atrophic rhinitis. Secondary to radiation therapy, if the patient has taken cancer radiation therapy. Now we have specific brachytherapy and all that. Earlier days when the radiation is given, it will be given to the entire head and neck area. At that time, patient can develop post-irradiation atrophic rhinitis. Now the cases have reduced. Also, atrophic rhinitis can develop if you do a radical surgery of the nose. That is, a lot of mucosa is removed, the entire turbinate is removed. So, radical the removal of the nasal turbinates and nasal mucosa can result in post-operative atrophic rhinitis for the patient. That is why now we do mucosa preserving surgery. See, even if you have to go for a turbinate reduction, we do a turbinoplasty instead of a turbinectomy. So the mucosa is preserved. What is the pathology? The pathology is mainly there is chronic inflammation and then there is osteomyelitis and there is destruction of the turbinate. There is squamous metaplasia. What is squamous metaplasia? So the normal nasal mucosa is ciliated columnar epithelium. So this ciliated columnar epithelium due to chronic irritation is replaced by squamous epithelium. So the cilia is lost. That is what is known as squamous metaplasia. There is reduction in the number and size of the alveolar glands and also there is dilatation of capillaries. Pathologically, histopathologically, there are two types of atrophic rhinitis. Type 1 is there is end arteritis or periarteritis. That is the arteries are destructed due to the inflammation, mostly in chronic infection. Another type 2 is where there is dilatation of the capillaries and the endothelium lining the capillary cytoplasm will be larger in size compared to the previous normal cell. And also they stain positive to alkaline phosphatase. That means there is more of bone destruction and hyperemic decalcification can occur and destroy the bones. And some bacteria, especially this Klebsiella ocina bacteria and all have celiostatic activity. That is, we have the ciliated columnar epithelium. The cilia is continuously moving and clearing the secretions. So cilia function is disrupted, and there is stagnation of secretion. There can be more and more infection. So it is a vicious cycle. In pathology, we can include two more things like reflex sympathetic dystrophy syndrome, in which there is vasodilatation, dilatation of the capillary, and there is hyperemic decalcification. Also, in conditions where there are surfactant deficiency, there is ciliary dysfunction, which again can cause reduced mucociliary clearance, stagnant of secretions, bacterial infection, and atrophic rhinitis. A milder form of atrophic rhinitis is known as rhinitis sicca. The more severe form is known as osina. Atrophic rhinitis is also known as osina. What are the presenting symptoms? How does the patient present? The patient presents with bleeding from the nose, that's epistaxis. Patient presents with nasal obstruction. The patient can present with the loss of smell, nasal discharge, purulent nasal discharge, headache, all the symptoms. The patient can also complain of chronic cough and throat irritation, because the patient can also have a dryness of the pharynx, also known as pharyngitis sicca. So there can be mucosal atrophy of the pharynx, chronic granular pharyngitis associated with this. Also, patient can complain of some choking episodes or recurrent cough, because the nasal crust can dislodge and come into the throat, causing the choking episodes. Also, generally, you can find that these patients will be a little bit psychologically down or depressed because of the chronic symptoms. And also, you have to take a history of any other granulomatous diseases, history of tuberculosis, syphilis, leprosy, all that has to be ruled out. History of previous surgery, previous therapy, all that has to be ruled out in your history to classify whether it's a primary atrophic rhinitis or a secondary atrophic rhinitis. On examination, we will see that the nasal cavity is full of pus or purulent discharge and also crust, which is greenish to black crust. And we can see that the nasal cavity is very roomy. There is a lot of space in the nasal cavity, but still the patient will be complaining of obstruction, and also foul smell will be there. Earlier days and all, when the patient walks into the OPD itself, you can get the smell. Okay, this can be atrophic rhinitis. So that kind of foul smell will be there from the patient's nose. But the patient will not feel the smell. Patient will not feel any smell in the nose. Patient cannot feel the smell of other things also. Patient will have anosmia. That is also known as merciful anosmia, because it is too much foul smelling. So it is a mercy that the patient is not feeling the smell. So that is merciful anosmia. It can be an MCQ. Merciful anosmia is seen in a condition known as atrophic rhinitis. And also patient will complain of nasal obstruction despite a roomy nose, because all the turbinates are destroyed, the mucosa is destroyed. So there will be a lot of space in the nasal cavity. But the thing is, patient will complain of nasal obstruction. I'll tell you why patient complains of nasal obstruction. Before that, when you remove the crust, the patient will be bleeding. While you remove the crust and all, there can be bleeding from the nose. Why patient is having anosmia and nasal obstruction is because we have lot of nerve endings in the nasal mucosas, especially in the nasal valve areas. The nerve endings are destroyed, blunted, or atrophied. So we will not feel the sensation of the air moving. So this nerve endings only will detect. So if I am touching my hands, the touch is preserved by the nerve endings. So the nerve endings are destroyed means the patient is unable to perceive the movement of air. So the patient will feel that the nose is obstructed. Also, there is no resistance between the nasal valve and the turbinate area and all that. If you refresh your physiology, you will know there will be development of eddy currents in the nose. There will not be any production of eddy currents in the nose, and also blunting of nerve endings. Patient feel obstructed in spite of a roomy nasal cavity, and also patient will not have any sense of smell. What are the investigations that you can do? You can do a general blood investigations to rule out any nutritional deficiencies, iron, protein, vitamin levels, all that can be assessed. Also, nasal swab can be taken to do the bacterial culture sensitivity. We can do a saccharin test to assess the mucociliary clearance, whether the cilia are functioning or whether the squamous metaplasia has already happened. The mucociliary function will be reduced. The clearance time will be more than 1 hour and all in these patients. The differential diagnosis is secondary atrophic rhinitis, which is syphilis, leprosy, tuberculosis, and all that. So to rule out that, you can do VDRL, TB test, NALDO test, or nasal swab, PCR test, all that can be done. Leprosy test, all that can be done. Along with simultaneously, the patient can be investigated. Also, you can take a CT, PNS for confirmation. CTPNS will show all the changes. That is the roomy nasal cavities, atrophy of the terminates, atrophy of the maxillary sinus. There will be mucosal thickening of the paranasal sinuses, the loss of definition of the osteometal complex due to resorption of the unstayed process, the ethmoids, etc. Nasal cavity will be fully enlarged, and there can be erosion of the lateral nasal wall. And also this erosion and bowing of the lateral wall and the enlargement of nasal cavity and all seen in CT means it is a later disease. It comes in the later stage of atrophic rhinitis. So we can assess the severity of the disease also with the CT. What is the treatment? Conservative or medical treatments are available. The main treatment is to remove the crust and washing the nose. So for nasal douching, we can use a solution of sodium chloride, sodium bicarbonate, and sodium diborate. The sodium bicarbonate helps to loosen the crust, and sodium diborate acts as an antiseptic. You can also give our normal saline for nasal douching 2 or 3 or 4 times, how much ever time the patient is able to do it. The patient has to clean keep the nose clean so that the crusts are removed and the foul smelling pus, everything is cleared off. If the patient is coming to the OPD, crust can be removed under visualization with forceps or using mild suction. When you remove the crust, it will bleed a bit, but that is okay. Other drops that can be used is 25% glucose and glycerin drops can be used. For histopathologically confirmed type 1 atrophic rhinitis, where there is periarthritis and endarthritis, you can use estradiol sprays or estradiol drops can be used. Other treatment that can be given is chemicitin anti-oceana solution. It's an antibiotic, a topical antibiotic solution comprising of chloramphenicol, estradiol, vitamin D2, propylene glycol, etc. Also, you can give oral antibiotics. Oral antibiotics can be given according to the pus culture and sensitivity also. And oral antibiotics also will help to reduce the amount of pus formation, the fever, the smell, everything will reduce with oral antibiotics. Other treatment that you can give is potassium iodide or Mandel's paint topical application. And oral potassium iodide is given to increase the nasal secretions. A lot of other topical treatments are available. Neostigmine sprays, placental extracts. Placental extracts are available as gel forms and also injectable forms. This will increase immunity and regenerative capacity of the nasal mucosa. And also we have to correct the hormonal deficiencies or vitamin deficiencies, if any, if the patient is having. Iron supplements, vitamin B12 supplements, vitamin D supplements also all can be given to help the healing of the mucosa. Now coming to surgical treatment, our aim of surgery is to help the nasal mucosa heal. So we can help healing by reducing the volume of the nose. Where the nasal cavity is big, so a lot of turbulence of airflow is there. So you have to reduce the volume of air so that the trauma from the turbulence of airflow is prevented. Also, the mucociliary activity is reduced, the mucous glands are atrophied. So you have to increase the secretion of the nasal cavity. And also the vascularity of the nasal cavity has to be increased because of the ENT arthritis. The vascular supply is reduced with any procedure that helps to increase the vascular supply to the nasal cavity is there. It will promote healing. Coming to ENT operation, what is ENT operation? ENT operation is closing the nasal cavity completely so that it will help healing of the nasal mucosa. We have to remove all the crust from the nasal cavity, all the secretions, everything is suctioned out. And after infiltration, we put a circumferential incision just cephalic to the alar rim, just inside or posterior to the alar rim, and elevate 2 flaps, inner mucosal and an outer cutaneous flap. And these 2 flaps are sutured in the midline and the entire nasal cavity is closed. And after a few months, like 9 to 12 months, or we can wait till 18 months, this can be recanalized. And before recanalization, you can see the status of the nasal cavity through a posterior rhinoscopy examination, whether the mucosa has healed. The main aim is to reduce the turbulence of airflow and the trauma due to the turbulence of airflow and help in mucosal healing. Your ENT operation can be done in a staged procedure. That is, initially one nose is done, then the opposite nose can be closed. Nowadays, we do only modified Young's procedure. It is the same as the Young's procedure. We have to clean all the crust, remove all the secretions, everything, and just posterior 0.5 centimeter posterior to the mucocutaneous junction, we put a circumferential incisions, and then inner mucosal and outer cutaneous flaps are raised, and the flaps are closed in 2 layers. We can insert a small 3 mm polythene tube in between the flaps and close it so that there will be 3 mm hole in the nose. In this, a little bit of nasal breathing is preserved. In Young's operation, complete nasal cavity is closed and patient has to breathe through the mouth only. But here a 3 mm hole is there, so some nasal breathing is preserved. So cosmetically it is a little bit better. Another thing is we can use a small pediatric endoscope, 2.7 mm endoscope, and see inside the nasal cavity. The healing status can be assessed. Also, if you have to instill any antibiotic or glucose and glycerin drops, you can do through the small hole that we have left. The tube can be removed after 1 week, and the hole will be there, and later we can rest. Usually, the inner mucosal flap is sutured with 4-0 and the outer cutaneous flap is sutured with 3-0 Other procedures that are used to reduce the volume are a Lawton-Slogger's procedure, in which the lateral wall is medialized to reduce the volume of the nose by injecting submucosal injection of paraffin. Another procedure is Wilson-Sisson, in which submucosal injection of Teflon paste is used to reduce the volume. And also, some mucosal implants can be done. Sublabel implants can be done using bone, cartilage, fat, Teflons, elastic sheets, etc. to reduce the volume of the nose. Also, there is a surgery known as vestibuloplasty, in which the flaps are elevated in the vestibule, and these are used to cover the turbinates. So, all these are minor procedures that are used to reduce the volume of the nose to help healing. The procedure that can be used to produce vasodilatation and increase blood flow is stellate ganglion block. So, this will increase the vascularity and increases the blood flow. Same action estrogen has. Estrogen also causes vasodilatation of the capillaries and increases blood flow. That is why it is used in type 1 atrophic rhinitis. In type 2 atrophic rhinitis, already there is dilatation of capillaries, so estrogen sprays are contraindicated. Another surgery is salivary irrigation, that is to bring about lot of secretions and lubrication to the nose. That is Wittmaack surgery, in which the parotid duct is implanted into the maxillary antrum so that the salivary flow will irrigate the nose. What are the complications of atrophic rhinitis? The patient, if untreated, can develop septal perforation, saddle nose deformity, nasal myiasis, especially in neglected cases and debilitated conditions. The Chrysomia species will lay eggs, and the patient will develop nasal myiasis and chronic dacrocystitis. Because the nasal cavity is fully crusted and infected, the lacrimal duct will get blocked, and also atrophic pharyngitis. These are all the complications of atrophic rhinitis. Hope this helps. Thank you.